am going to give you a little historical perspective for old guys like Dr. Turi and myself. So to understand the process we all went through about revascularization strategies. How do we decide? It's now a more scientific base, but earlier on, before data like syntax, it was clinical presentation, patient preference, and then went back to the anatomy and the heart team discussion, which we'll hear several times today, about whether we think we can offer complete revascularization. That's a big item, though, is complete revascularization. So the CABG gives you that. Bypass surgery gives you the advantage of complete revascularization. The Lima to the LAD is, if in diabetics and non-diabetics, an almost unbeatable revascularization strategy. We've been difficult to beat by stent. It is durable, we think, for a while, and offers almost immediate symptomatic improvement. The disadvantages is surgery. Is vein grafts have between a 5 and 15-year not survival, I guess, durability. There is progression of native disease, and I'll show you the cerebral vascular events that occur during surgery. And some people think once you cracked your chest, that's your only opportunity. PCI is we're not filleting you open like some physicians have described. It is this tiny wound in your wrist that I'm going to open all your arteries. Really dramatic reductions and almost no CNS events, though we see more with radial than we've seen from the groin, and can be repeated. And I would argue that the greatest disadvantage of PCI is incomplete revascularization. That's a big item, I think. Let me give you some historical studies, talk about where we are drug-eluting, and then a couple of the guidelines which have really not kept pace with the data to thus far. So for those of us a little gray hair in the room, in '96, this study was published, and most physicians received a letter at home saying that angioplasty was higher, mortality was higher with angioplasty than bypass surgery, and you should consider surgery in your diabetics with multivessel coronary disease. We were starting to evaluate the use of angioplasty versus bypass in these patients. You can say that's, and again, if you exclude the diabetics, there was no difference in MI or mortality. That's, many, many years ago. And then that conclusion rings through many times, and you'll hear it again and again today. If you follow these patients with their 7-year follow-up, again, bypass had greater total survival benefit as opposed to angioplasty, and all due to better improvement in the diabetics. The revascularization rate of angioplasty, as you can imagine, is closing in on 60%. So basically 1 in 2 patients would come back for some repeat procedure of plain old balloon angioplasty, and we had more frequent angina. This is the survival curves, again, presented back in '96. Again, if you really look at it, there's no difference in the survival curves, no difference in survival from myocardial infarction. However, when you differentiated out the diabetics, this is what was presented. This was brought the FDA to publish that letter and send it to us all that we should avoid PTCA and diabetics. This was the Achilles heel that we all talk about. And this is from a whole variety of studies that predate, the German experience, the Emory experience. All of them showed very similar results that, MI, non-diabetic MI rates and survival rates were comparable, non-diabetic. But even in the non-diabetics subset, you have a significant increase in repeat revascularization, up to 40% in some studies, up to 40 and 60% in others. So repeat revascularization has been and continues to be the Achilles heel of multivessel percutaneous intervention. Quickly going through another more conventional stent study prior to drug-eluting stent was a stent versus surgery study. Really, again, heart team came together, looked at the anatomy together, and again showed no difference in death or non-fatal myocardial infarction. Again, up to 3 years, and you'll see this again. Here's the Achilles heel. You had a 4-time increase of bare metal stenting, a revascularization as opposed to surgery, followed out to 3 years. In this particular study, showed kind of an interesting trend that in diabetics they did see a reduction in kind of the death in MI as opposed to the non-diabetics. Excuse me, no difference in events. So again, kind of take into account perhaps selection bias. There was no use of any scoring system. This was really the heart team came together and said either one could done. So kind of flies a little bit in the face, and you do see some variability in the studies, but the general theme is that diabetics do better with surgery as opposed to. Again, in this particular study, bare metal stents, PCI versus CABG, not with a team approach, not a scoring system, that the outcomes were favorable in both groups, but both groups had reasonable adverse events. PCI was associated with repeat revascularization in the bare metal stent day. So it was better than PTCA, but maybe not the end all. Let me skip over this. Here is the more conventional study published in 2012, which is this syntax study, which is what we're discussing somewhat today. This is the scoring system. So I highlighted in red the local heart team approach. They all came together, used scoring system, the Euro score, which includes some clinical, and the Parsonage score, which is more of a clinically based score. And then looking at each one of these variables, the dominance, the number and location of lesions, the left main in and of itself is given a score. Three vessel disease, CTO, tortuosity. Oh my God. I'm going to talk really quickly here. It's only have 10 minutes left. So this is points that you're given. So not only do you have a lesion, but you're assigned a point based on that lesion. So for example, left main is given 6 points. So if you have left main stenosis, you immediately get 6 points. And then as you march through, you can see depending upon dominance and others. And then again, you're given points, weighted score based on trifurcation, bifurcation, aortosteal thrombus, and calcification. And then as an example, this is someone who has left main stenosis, has proximal RCA stenosis, and has proximal circ stenosis. Now the left main was gated as a Medina, which is a scoring system of 100, so it's only involving the left main, not the prox LED, not the circ. So that lesion was given points. The proximal RCA was given points, which was really a lower score because it's only a focal lesion, and the proximal circ was given a low lesion, given this patient's overall syntax score of 18. So he really is in the low risk category, and PCI would be considered here as an alternative for this patient, strongly considered actually. Here's the syntax score, or the syntax study, excuse me, left main, isolated versus multivessel coronary disease. The other subset was just strictly multivessel coronary disease, a whole host of exclusions, but really the heart team sat together. What drove a lot of discussions. Again, here is some of their data: 3.5% for CABG, for the Taxus, which is a stent that we do not use currently, was a first 1.5 generation drug-eluting stent, paclitaxel. It was felt to be a comparable death outcome, which is you've heard before, comparable in death. The Achilles heel of surgery is this stroke risk, which is essentially double plus in this particular study, cerebral vascular events. If you're looking at all-cause death, MI, or cerebral vascular event at 12 months, they're comparable. The two strategies are comparable when the scores are comparable. If you look at repeat revascularization, once again, the difference is marked. That we do have, here's 1.5 times increased risk of need for repeat revascularization. I'm trying to get through quickly. If you're looking at major cardiac and cerebral vascular events to 12 months, again, kind of driven by revascularization in favor of CABG over PCI and multivessel coronary disease, strictly multivessel in this instance. So looking at the syntax scores. So if you have a low syntax score, 0 to 22, again, comparable, actually favoring somewhat with respect to cerebral vascular events, favoring PCI. If you have that intermediate gauge, which is what our patient came out to be, 27, you have, again, favoring CABG somewhat, but again, it's reasonable to have a discussion based on statistical analysis. And again, in multivessel disease, non-left main. And then if you're looking at 2 years for surgery, clearly favoring CABG in those high syntax score patients with multiple lesions and complex anatomy. So their conclusion is comparable safety outcomes, which again, even from 96 to current, death and MI are comparable in comparably selected patients in CABG and PCI at 12 months. That's significantly higher rates of revascularizations with PCI. and a higher rate of cerebrovascular events in CABG. That the major adverse cardiac and cerebrovascular events was higher in the PCI groups, driven mostly by revascularization. And that it's very helpful to have a scoring system like Syntax, and we've really embraced it in clinical practice. To discuss it a little bit further, the FREEDOM trial was looking specifically at diabetics, because that's a large group, not germane to our patient, but I thought was worthy of a discussion today. Just quickly describe multivessel stenting versus CABG in these patients. Really very comparable group, if you will, really kind of preponderance of men. Syntax score in this particular group was nearly identical. So they're a normal ventricle, very moderate Syntax score, moderate number of lesions, show that PCI in diabetics, who despite current therapy and Gen 3 DES, again, it favors CABG over PCI in those individuals going out to 5 years. So again, we've not beaten back the diabetics yet.
So that's an interesting curve, though, because if you stopped at 2 years, like some of the other trials we saw that were presented first, like Syntax, then they look identical. So you're talking about significant long-term improvement in CABG.
Correct. Right. And it goes back to the senior patients and older individual. Correct. Myocardial infarction. Interesting was, again, early on, no difference, but later on, there was an increase in myocardial infarction, considering perhaps the type of stent was used. All-cause mortality, again, kind of in favor of CABG, driven mostly by repeat revascularizations and myocardial infarctions. Stroke favored PCI as in other studies. And then they adjudicated by Syntax. So even in this particular trial, in the diabetics, the low Syntax scores still favored bypass surgery, which was interesting, which really flies a little bit in the face of the original Syntax score study. Again, low, the intermediate, again, favored significantly, but it's way out at 5 years, it really the curves diverge, which is really quite interesting. So kind of a more school for thought that the diabetics truly are better served by surgery. And again, not to belittle the issue, but you can see that the entire scatter plot, this is the line of equivalence here. If you're on one side of the line, you're statistically favored. If you're on the versus the other, if you cross the line, there's no statistical difference. But in many variables, bypass does well. And for example, if history of stroke, they still do, and with no history of stroke, they do better. Just as an example. As my time is running out, I'm going to skip through quickly. This is the BEST trial. This is just another study looking at multivessel bypass surgery by S.J. Park, a very distinguished group interventionalist in Korea, who again show the composite endpoints. Kind of slow, but I really wanted to kind of just drive home the point that they really have a reduction in events, composite endpoints, with CABG across the PCI. And when they look at composite endpoints and repeat revascularization, again, that's driven even more so. Go through a little quicker. The diabetics, if you're non-diabetic, even in this study, if you're non-diabetic, the mortality is comparable. So again, if you're non-diabetic, MI, death, is comparable with repeat revascularization. If you're diabetic, clearly you should be thinking about surgery.
If you go back one, it looks like the low Syntax score was a toss-up as well.
Yeah. Again, it's in the non-diabetics, it's really kind of it really is a dealer's choice. Skipping through because in interest of time. Here's some guidelines for because it's early in the year. We really should discuss a little bit of the guidelines, and they have really tried to keep pace. That lima with CABG with lima to the LAD improves survival both in diabetics and non-diabetics. I would completely agree with this statement that it's difficult to beat a lima to the LAD. It is reasonable to choose bypass surgery over PCI to improve survival with complex three-vessel disease, complex intermediate with or without involvement of the proximal LAD. Well, many of us, as in our patient, had proximal LAD involvement, so I thought very reasonable to offer in bypass surgery. But if you don't have proximal LAD involvement, we have a better discussion to have, I think. Heart team discussion. Well, bypass was improved for patients to improve survival in diabetics. Clearly should be thought of upfront in our diabetic patients. That's why out of the cath lab, you'll see us kind of referring off our diabetics for multivessel bypass based on data like this. And if you have two epicardial vessels non-involving LAD, and without extensive ischemia. You know that that's the consensus statement that perhaps CABG is not as useful. Perhaps those patients should be thought of for intervention, percutaneous intervention. And I guess this would be a very low syntax score based on only 2 vessel stenosis. So to run through quickly, a lot of discussion. Choice of patients was individualized based on age, diabetes, comorbidities, anatomy, patient preference. All of them came into play here. Heart team discussion, 3 interventionalists chimed in our discussions as to what to do. I would suggest no difference in mortality or MI with lower costs in the non-diabetic individual with low and intermediate syntax scores. I think the data is substantially set from 96 to present. So it's very interesting that it's been very consistent in that the high syntax scores favor CABG. That if you look at your diabetics, CABG is preferred over PCI based on syntax study, based on the FREEDOM study, based on the BEST study. So you have a lot of data supporting it, especially diabetics with multivessel disease involved in the PROX-LED. That the syntax score does help you risk stratify. It's very useful in this case. Was useful discussion to have, and we do use it routinely. And again, ending with the heart team discussion. It's really good to bring everybody to the table to discuss it, including the patient's preference. Thank you.